And now for an amazing presentation, I'm very happy to introduce Dr. Noel Bairey Merz. Dr. Noel Bairey Merz is the preeminent investigator in women's heart health. She is the director of the Barbra Streisand Women's Heart Center at Cedars-Sinai Heart Institute. Dr. Bairey Merz is, perhaps her greatest distinction is being a Texan. She's was born in San Antonio, right? And then from there she went to some illustrious places, undergraduate, University of Chicago. Then she went to Harvard for her medical training and to UCSF for her finishing, more residency and fellowship. And now is at Cedars-Sinai as a professor there, professor at UCLA and professor at Cedars-Sinai. And she has a lot of titles, but the ones that are important to mention is that she is the Women's Guild Endowed Chair in Women's Health, the director of the Barbra Streisand Women's Heart Center, the director of the Linda Joy Pollan Women's Heart Health Program, the director of the Erica J. Glazer Women's Heart Research Initiative, director of the Preventive Cardiac Center, and professor of medicine, as I mentioned, at Cedars-Sinai. She has taught me a lot, taught those of us in the profession of cardiovascular medicine a lot about women's heart health. She was the principal investigator for the National Heart Lung Blood Institute WISE study, which you're going to hear about, Women's Ischemic Syndrome Heart Evaluation. And the WISE study taught us that women's coronary artery disease is different from men's coronary artery disease. Really some fundamental insights from that program. She's continued to do research in women's heart health, and we're going to hear a little bit about that today, so I won't take up any more time. Dr. Noel Bairey Merz, please join me at the podium. So proud of you.
Yeah, vice versa. John and I go back. We first started working together judging scientific abstracts, if you remember, and because you were the translational guy and I was the clinical gal. So, and we both lived in California for a while. So it's an honor to be here, and delighted also to hear about this fabulous partnership between Rome and Houston. And I am a native Texan, although my father was in the Air Force, the U.S. Air Force, and we moved when I was about 6 weeks old, and my mother said that was a really good thing because the cockroaches were bigger than I was. All right, this makes it go forward, I bet. So I was asked to talk about women's heart health, what you need to know, and it will be a mixture of fact, some research. We'll talk about guidelines and how we've actually improved cardiovascular disease around the world. And I'm going to end with some messages about advocacy, which I think will really resonate with your organization. So here's where we were and actually where we are. This is now a dated publication. You can see it's 17 years old, but it actually hasn't changed. More women die of coronary heart disease, CHD, than breast cancer at all ages. And most people, when they see this or hear this, are shocked. There's a gasp. And you can see that the red bars outpace the yellow bars dramatically, even in our young women, 15 to 24. How can this be when we know that breast cancer is one of the most prevalent forms of cancer? Two facts. Number one, we're curing a lot of breast cancer, and this is a death slide. And you know, how many of you know someone who has been treated and now is a 5-year cure of breast cancer? Yeah, I know. I have a bunch of women friends. Okay. And then the other thing is, half of the time that heart disease strikes, it kills you instantly. There's no going to the emergency room. There's no getting to see the cardiologist. It's sudden death. So this is why cardiovascular disease continues to be such a big problem. And as you can see, if women wanted to own a problem, a health problem, we would own cardiovascular disease, unlike the popular assumption that it's breast cancer. So I got involved in the late 1980s because for the first time, investigators, as well as our National Heart, Lung, and Blood Institute, started to sex stratify the data. What does that mean? When we were counting up cardiovascular disease deaths, we started putting the women on one side and the men on the other side, and we noticed that these curves were changing differently according to men in the black bar, where we were really winning the war on cardiovascular disease, compared to women in the red bars where, wow, not only were we not winning the war, it was going up. It was going up. And this led us to say at the national level, because this is too fast of a change to have a change in genetics or just a simple change in cigarette smoking in less than 5 years, that doesn't make sense. So this led a lot of us to say, hey, I wonder if the detection, diagnosis, and management strategies that we're using that have been adopted since the 1950s, 60s, and 70s in men, for men, and by men, maybe aren't working very well in women. In fact, these trends have continued, and one of the emerging groups that account for the increasing death is young women. So here's new data from New York City, and the young men are on the right. The font is small, I apologize, but these are aged 35 to 54. That's considered young. So the men are on the right, and you can see that these young men continue to trend down. We still are winning the war on cardiovascular disease in men. What about the women? Stagnant. And what about non-Caucasian women? Going up, going up. So the new epidemic, in addition to the 1984 epidemic, is young, middle-aged women. Actually, cardiovascular disease is on the rise. Some of this may be related to other things that are going on. So here are, we have a large study, the NHANES, and every 3 to 5 years, man, woman, and child are randomly sampled in the United States. So we get sort of a sense of a lot of different things, height, weight, et cetera. This is blood cholesterol. And what you can see on the right in the women is that cholesterol levels are going down for our older women, just like the older men. Cholesterol levels are going down in the midlife men, but it's not going down in the midlife women, and it's going up in the young women. So again, something is very different about cardiovascular disease between women and men. So these are two very noteworthy women. I bet most of you know who the woman is on the right. That's, of course, Barbra Streisand, who produced, directed, and starred in her movie, The Yentl. And if you recall that story, and it explains why she's dressed up like a man in this photo, turn of the century Europe at that time, for a woman to become literate, to be able to read and write, you had to impersonate a man. You had to be a man. So she impersonated a man, and it's a wonderful movie. The gal on the left, you probably don't know who that is. That's Dr. Bernadine Healy, a clinical cardiologist, investigator similar to the cardiologist you've been hearing from today. She was the first female director of our National Institutes of Health. And she looked at that curve crossing in 1984, and she wrote in the New England Journal of Medicine, I think we're seeing this increased death, cardiovascular, in women because they don't look like men. They're not being recognized. And I think we should do something about it. And because she was the NIH director, she did. So she put into place a variety of big studies that I will elaborate on our heart study to respond to this kind of stuff. So here's Reader's Digest. I have to apologize to our Italian friends. This is a magazine that a lot of people read. In 1995, wives would take a test for the husband. Never for themselves, of course, because, of course, women didn't have heart attacks. All right, and this is what they were supposed to be looking for, and this is the Hollywood heart attack, right? If you had to describe what does a heart attack look like, this was depicted in movies and television, and even the American Heart Association tells you this is what a heart attack looks like. So you know, a lot of work. Here's what heart disease looks like in women. And again, this came out about 5 years ago, but it's the result of a lot of research. We're finally studying women. And it turns out women having heart attacks can have a variety of symptoms. Doesn't all look like the Hollywood heart attack. The other thing to say about this, in case any of the men in the audience are starting to feel left out or upset, 1/3 of men will present with these types of symptoms. They're called atypical. And so we're going to do, if we can do a better job recognizing women with heart disease and educating our physician workforce as well as the community, we're going to do better for women and men. Why are women's heart attack symptoms different? Well, that's a good question. So here's some WISE research done with Renu Vermani and Alan Burke at the Uniformed Health Services Hospital at the time, because they had a freezer full of sudden cardiac death victims looking at their hearts. And what they were able to show is the reason women have maybe more subtle or softer symptoms, a little harder to put into a basket of a Hollywood heart attack, all right, I'm not going backwards. How do I go backwards? Yes, I just went backwards. I was trying to use my pointer. On the top, this is a coronary artery cut cross-sectionally. Women tend to erode this fatty plaque cap and distally have little blood clots that kind of sprinkle down, kind of like a stream, and so they might, now I feel pretty good. I'm a little short of breath, but now it's gone again. And the EKG can also kind of look like that, little wavelets, where men are much more likely to explode, to actually rupture the cap on their fatty plaque. It makes a big old blood clot, and it makes a heart attack called a STEMI, which is really easy to recognize, and any medical student can do it. Is this 100% different? Women always erode women? No, but there's a sufficient difference that it can account for this surplus of deaths because women weren't recognized because of this subtlety. We were also, working with the Cleveland Clinic, able to match our women's coronary angiograms and using a technique called IVUS, intravascular ultrasound, to demonstrate that male pattern fatty plaque buildup in the coronary artery is different than female pattern fatty plaque buildup. And the analogy here, so again, a third-year medical student could do this. Where's the blockage in panel A? Where's the fatty yellow blocking? Right, you can see it. Where is it in panel B? Yeah, in the woman. But you can see the red line at the graph, the pressure line. They're equally down in both. So the woman has just as much risk or heart attack as the man. It's just that the fatty plaque buildup looks different. And we're used to looking at that male pattern, so our cardiologists always recognize that, and they're going to miss panel B. The analogy, and we're looking at this now with microRNA and different ways that we know that we can lay down fat, is that men typically have a more male pattern fat deposition. When men become obese, where does it go? In a fatty, bulgy area, right? Beer belly. When we become obese, women, or overweight, how about that? It's that yucky cellulite, but it's right underneath the skin, and it's everywhere. So women appear to be better at putting away the garbage, which is true, right? We know that, where men have this focal plaque. So we've also worked hard in a number of WISE studies to develop new or existing tools to better understand this, what we now call coronary microvascular dysfunction, because the women are capable of having ischemia, which is an abnormal blood flow, and heart attacks with that kind of arterial pattern. Nothing is plugged up, but the flow is abnormal. So this is an example of a cardiac MRI. So this is an advanced imaging, and it is one of the few modalities, MRI or PET, that can now diagnose this. And in centers of excellence, this is now available. In the United States, I know that it's available in Italy because I work with those investigators. So Let's look now at this failure of pattern recognition and what might be potential consequences. So what we can see is that when Barbra Streisand here dressed up like a man and what we call an obstructive coronary or a male pattern, we can see that that will trigger the therapy, RX, which there's 4 life-saving pills that are our guidelines. Like if you're having a heart attack, the cardiologist needs to prescribe these, and if they don't, the hospital gets into trouble for quality marks. Low-dose aspirin, beta blocker, ACE, and statin. Barbra Streisand dressed up like a woman with her husband, microvascular CAD, or a female pattern. You can see that it's probably about 25 to 30% of the disease burden, and yet because they are not recognized, they don't get the life-saving therapy. They are not treated typically, and you can see the surplus of death on the right is dominantly female. So this is what we sort of think is going on. More men receive treatment and more women die. And the treatment that we have works pretty well. So it's a disparity. It's a health disparity, something that I think your organization could address. All right, so that's 20 years of work. And one of the things that we say as investigators is that we create evidence to advise guidelines, which then advise clinical care. And docs don't inherently know what the right thing to do is, which is why they're always reading their journals and trying to keep up, right? Continuing medical education. So since we've been on this bandwagon and we've been working hard, here has what happened up through the early 2000s. So the National Heart, Lung, and Blood WISE study, which I chair, as Dr. Cooke told us. We also had awareness campaigns, National Heart, Lung, and Blood, and the American Heart, the Red Dress Awareness. And then we've been very active on these guideline campaigns because dominantly when you dispense those medications to the right patient, you mostly save women's lives. Men were already getting guidelines therapy. So we're pretty proud of that. I was asked to talk about the evidence behind why we think our lifestyle choices are good for cardiovascular disease, and to arm you with personal information that you might want to take home and deploy amongst yourself. So this is before the 2016 election. This is from 1997, but it's just an example of you can't believe everything you read. But, you know, get someone who you actually think knows something about it and listen to them. So I'm going to hopefully tell you something about it because I think I know. I am a preventive cardiologist as well as an investigator. So here's data from the Women's Health Study, which is that very large study started decades ago that dominantly is comprised of nurses. And why did Dr. Joanne Manson reach out to nurses? Because they can take their own blood pressure, they can take their own blood and mail it in. They're pretty good about measuring things carefully. So this data is pretty darn good. And at that time that she started it, all women. Nursing was an exclusive women profession. All right, so here they are. Mediterranean nutrition, we're going to talk about that. Non-smoking, that's a no-brainer, but we're going to talk about young women. Non-obese, and we'll define what that means. And then at least 30 minutes of some type of physical activity, and then at least 1 serving of alcohol. So these are the 5 health habits. Yes, I know, we'll get to it. These are the 5 health habits that when you read things, if we could actually do this on a daily basis, about 82% of heart disease would go away. It would become a less common disease. It would still be fairly common. So one of the things that I say regularly is 20% of millions is still millions, and we're still looking for the cure. So don't give up on us. We're looking at genes, microRNA, and issues of aging. But there are some things that you can control. So on the left is what our U.S. government thinks we should be eating. On the right is what's called a Mediterranean. These are broken down into, at the bottom, that's what you should eat multiple servings of per day, and then it goes up and up and up, and you can see that, for example, the U.S. government thinks we should be eating, meat 2 to 3 servings a day. And the Mediterranean style says maybe a few times per month and a very small portion. What are the differences in addition to that? Well, you can see the Mediterranean pyramid still has a lot of carbs, but they tend to be whole grain and they're less than the American carb. So the low carb fads are probably, reasonable. You can see a lot more fruits and vegetables, and you can also see a lot more nuts and beans and monounsaturated fats, which is the olive oil. So what is Mediterranean style? Is it, taking your pasta, taking a big old bowl of pasta and taking the crusty bread and, dipping it and consuming a cup of olive oil? No. But it is making sure that you eat this kind of food every day, often in multiple servings. This is salmon or other types of fish. Olive oil or canola oil is the other monounsaturated fat that's readily available. Avocados, and then nuts and beans. And these are things that we don't eat enough of, except maybe our Italian colleagues do. And look at how many lives we would save if we could eat this way. And again, it's not, how many people know they shouldn't have burgers and fries every day? Everyone knows that. Okay, so how many people knew you weren't eating enough of this? This is usually, yeah, exactly, good information. All right, now, there must be something good in those foods, right? So why isn't it okay to just take a vitamin, right? Have the hamburger and fries and then take a vitamin that has the fish oil, or take a vitamin that has the ingredients in avocados. Well, it turns out at least 23,000 Americans, who knows how many around the world, end up in the emergency room after taking a supplement. In the United States, our over-the-counter supplements were deregulated by President Reagan, and that means that they can put anything in that, and they can tell you anything they want about it. Completely deregulated. Most of the basic ingredients now come from China, just like everything else comes from China. So, and remember the pet, they killed a lot of pets with that melamine. They killed a few kids with the dry milk. So we're not real big on supplements. 4 out of 5 herbal supplements tested by the New York State Attorney General's office don't actually contain what's on the label. So the only good news about the supplement industry right now is that actually they can it's more profitable if they put a little talcum powder in those capsules and sell it to you than actually going and getting the ginkgo biloba, which is kind of expensive. So it's just expensive urine. Okay, non-smoking, everybody knows this, but here's the concern, and again, women hold up the sky. Women were key in Mothers Against Drunk Driving. I mean, find a social initiative that saved lives. It was typically led by mothers. Our daughters are now starting to smoke in college, and they say they're doing it for weight management, which is really, goofy. So and there are movements now to get college campuses to be completely smoke-free, and we have that in California. So this is an important initiative, and I would, have you advocate if that is not true in your own communities. Risk reduces the day you quit smoking. Most successful quits come after multiple attempts. There are very good drugs on the market now for the hardcore smokers, people that have been smoking for decades, multiple packs per day. They are addicted. It is a big problem, but we now have good drugs, and they are prescribed fairly freely, meaning you can typically go see a nurse practitioner, and because it's always, whatever the drug risk might be, it's safer than smoking. All right, passive smoke kills others, so again, be an advocate about smoking in public, which is not okay. Non-obese, all right, we have to define this. BMI stands for body mass index, less than 25, and I'll show you how to calculate it. A rule of thumb is being more than 20% overweight. And notice, it doesn't say non-overweight. So we're gonna talk about the obesity paradox. So what do these two gals have in common? They're both physically active, right? But one is very lean and one is not lean. All right. So here's the obesity paradox. When you look at body mass index, which is a calculation of how much do you weigh for your height, taller people should weigh more, shorter people should weigh less. The ideal body weight for women is between 22 and 25 for mortality. Okay, so if you want to say the ultimate arbitrator of health is whether you're dead or alive, it's kind of an important one. And it turns out that women do a little bit better, closer to 25 than men do. And again, this may be how women deposit fat, and the kind of fat that women deposit isn't quite as toxic as the fat that men do. Now, I'm not telling you to all become obese, and I'm not telling you to go out and eat your burgers and fries. But the pictures that were shown in magazines about what's healthful is actually at the left-hand curve. So every single model that you will see in a magazine has a body mass index of less than 18.5. Does that look healthy? No. So you know, we have to have sort of a realistic approach. This is a New England Journal article, but you know, they redo this every 10 years and it doesn't change. It does not change. Because body mass index is a very crude estimate of what we really are composed of, and that is body fat composition. So look at these athletes, these female athletes on the left. They have a very high body mass index. Some of them get into the obese range, and yet it's all muscle. Look at those girls' muscles. And you know muscle is denser than fat. So a really muscular person is going to weigh more. How about the guy in the middle? Where's his visceral obesity? It's all in his belly. That's the beer belly. That's the toxic fat, and that is more of a male pattern. And then here's our gal all the way on the right again, and that is her subcutaneous obesity. She is obese. She qualifies as being obese as well, but she's physically fit. So what you want to do is be fit, and if you're fit and fat, that's better than being lean and unfit. So physical activity turns out to be really important. So how do you get that muscle? That's what you want, muscle. At least 30 minutes of walking or some type of moving your body through space that can be, for many of us now with the smartphones, if you put it on your hip, that's 10,000 steps per day. That's called activities of daily living. It's not that hard. It's 30 minutes of walking, but if you choose to take the stairs instead of the elevator, if you choose to walk to get that latte, if you choose to park the car a little further, that's how you get your 10,000 steps in each day. So back to the fat or fit, does it matter what you weigh? This is another example. This is, of course, 25,000 men. So we replicated this study in women, which I'll show you next, finally. The average weight group, you can see, according to fitness levels, so unfit is in the dark red bars, moderately fit in the middle, very fit is in the yellow. And what you can see is it doesn't matter if you're an average weight, if you're above average, which we would call overweight, or if severely overweight, which we now would call obese, they all do the same. They all do the same. So it's not really about what you weigh, it's really about your fitness level and whether or not you've got that important muscle. This is how you get muscle. So we just talked about activities of daily living in the 10,000 steps. Most important for us, and I used to, say, Mom, you've got to turn the TV off. But increasingly, I have to say to myself and all my adult friends and patients, turn the smartphone off. Because being sedentary is a new risk factor. And sitting, today is okay. Today you're being educated. But sitting for prolonged sessions is also not okay. So what you want to do is activities of daily living every day, and then you want to have things that you do a couple times a week. And particularly for women, as we age and after the menopause, we lose that little bit of testosterone that we had coming from our ovaries. And so we really have to do some weights to maintain that muscle. And otherwise we become elderly and frail. All right, last but not least, my personal favorite, at least 1 serving of alcohol per day, right? All right, so alcohol has a mixed relationship with health, But defining it and studying it, 1 alcohol serving is 2 ounces of hard liquor, 2 fingers, 1 6-ounce glass of wine, not the fishbowl wine that you get on vacation, and 1 12-ounce can of beer. So that counts as 1 alcohol serving. 1 serving daily is associated with the lowest risk of mortality and heart disease. More than 2 increases risk. So again, we have a very J-shaped curve where people that can consume 1 a day or even 2 do better than people that don't drink at all. These are observational data, but they're very robust over and over, and no special type of alcohol appears to be better or worse. You hear a lot about the French paradox and red wine is better than white wine, and there may be issues that are related to other diseases. For example, red wine actually might be better for breast cancer risk, but not for cardiovascular. Just seems to be the alcohol. So if you wanted to drink medicinally, if you wanted to have those 2 shots of vodka, plug your nose because you don't like the taste, go ahead. Speak with your own health, personal physician. All right, now, what if you do all these things? Again, what we said in the nurses' health study was that 82% of heart disease could possibly be avoided if we did all 5 of these. Well, here's US data and more contemporary, and they, for whatever reason, didn't weigh these folks, so they only have 4 of the lifestyle habits. And you can see it's a graded effect. So going down is bad, somebody died. And you can see that people did all 4, did the best. People that did 3 did almost as well. 2, 1, 0. So the idea is there's no one of these things that is stronger or better than the other. And what you want to do is find things that are easily included in your lifestyle. And that you can share with others. Share with others in your family and your friends because, you're going to save a lot of lives. All right, so 5 health habits, nutrition, smoking, exercise, weight management, and alcohol, are strongly associated with avoidance of heart disease. The health habits are equally weighted, and they're cumulative. So, you can add on health habits as you get better. Okay, I should have looked at my slides. Sorry, lost in translation over the internet. We're going to talk a little bit more now about advocacy and why we really need to continue on this bandwagon that it's not okay for women to be second-class citizens when it comes to cardiovascular disease. You can't probably read this, but historically women have been underrepresented, and they still are. There is little knowledge about the effects of commonly used cardiovascular drugs in women, still. Practice patterns are based on research in middle-aged men, and there's limited information about therapies to treat the very elderly, which typically are women, right? Because we outlive the men. Sorry. This is just showing you in our FDA-approved as well as device trials. Almost always anywhere from 72 to 90% of the participants are men. Very few are women. Advancements in women's health research and changes in care have been purposeful, and I lost a picture. All right, here's all of the things that we've done in the United States. And again, this is an example that advocacy and wearing down your elected officials and electing women and then having the women band together to do these kinds of initiatives. And I'm going to show you a slide at the end that shows that it works. So one of the things that our most recent success that we really took probably 10 years was if investigators now are studying cells or animals to study a specific disease, they have to include female and male animals or cells. And what was, when we finally got to the right people, and they said, well, I don't know, it's all these male mice. And we said, yeah, but they're using male mice to study things like menopause and thyroid and, autoimmune diseases that impact women. That doesn't make any sense. All right, let's see if any of my other slides. All right, so at any time there have been major advances in women's health, it has been due to purposeful actions and not by chance. And I put these in when I saw the mission statement and the kinds of projects that your organization has taken on, that this would be just a perfect thing, and I'm so glad you selected it. And this is, oh, okay, let me tell you about one of the project chairs that I direct is the Erica J. Glazer Family Foundation. And Erica gave us an initial gift. Erica is a successful businesswoman. She's a co-owner of the Golden State Warriors, Go Warriors. She is an entrepreneur. She's like you. I'm sure she should be in your organization. So she gave us, well, when she heard this call that we don't have enough leaders academically in medicine, there aren't that many of me. Dr. Cooke got 2 out of probably 8 in the US that are leaders, Dr. Galati and myself. So one of the things that Erica's initial gift allowed us to start this annual National Women's Health Leadership Summit, and it is specifically directed at increasing the number of endowed chairs in women's health. And what does that mean? A professor like myself who can be a leader, the institution then gives them an endowed chair, and you can have the proceeds, the 4%, the 5%, the 7% in good years, to do projects, to support yourself, to support a junior faculty member. So the initial gift from Erica came in 2013. Here's what's happened since we've met annually. And this isn't random. This didn't happen by chance. This has been very specific, focused, targeted work. And you can see that all of those chairs now are full except for one, and we're actively planning our 2018 meeting, which we have in the fall each year. So as you've probably found on other projects that you've taken on, you know, if you need to get something done ask a busy woman. Barbra Streisand also heard our call and endowed our center dominantly for the unpaid. You know, we can pay for clinical care, we can get grants for research, so a lot of the endowment supports seed monies as well as education. The National Institutes of Health, which is our U.S. Major biomedical government, federal government, spent in the category of women's health within the National Heart, Lung, and Blood, $412 million. And that is less than half of the $1.1 billion spent on women's cancer research. Does that make sense? No. So we work hard to generate pilot monies to then make that different, meaning if you get a pilot grant and you get some preliminary data, you can go back. And not only that, hang on, where's my warrior slide? All right, well, I'll end with this. We got tired of National Heart, Lung, and Blood saying that that was all they had, you know, that they weren't going to spend any more on women's cardiovascular research. So we went to the Department of Defense, and some people might remember this, but when a lot of women were advocating for breast cancer research, this was in the 1970s, the women in the caucus, the female senators and Congress women, said, you know who has money? The DOD. And they put aside this congressionally mandated medical research. And so we went to the DOD and we said, do you want to get ahead of a problem? Because you have women in the military now, and you have a lot of women veterans who have PTSD from a lot of female issues. And so they agreed. So we just got a $15 million grant to study women's open artery using a clinical trial that will inform guidelines. So I will stop with that. Okay, thank you.